Knee joint actually is a really simple joint. It is hinge type of joint, all of you know. Movements, common movements are flexion and extension. So hinge, it is moving in only one plane. It is synovial type of joint. And how many bones are there? You can see almost 4 bones. So 2, 4. 4 bones are femur, tibia, fibula, and that hidden thing which is seen on the lateral view is patella. And it is forming 2 joints, patellofemoral joints and knee joint proper, which is nothing but a tibiofemoral joint. Then again moving to MRI, again acquisition we are taking 4 planes. So what are these 4 planes? Normal planes you all know, that is sagittal, coronal and axial or transverse. These are done in all these all planes are done in almost every MRI. But here in knee joint, we are taking one special sequence, and that is sagittal oblique. Sagittal oblique is basically we are taking these sequences in the line with ACL. So ACL can be seen from origin to insertion. Footprints are really important to look for the insertion site and the origin site of the ACL or any ligament as such. So here are 4 different planes where we are acquiring images, and if you look at the sequences, again 4 basic sequences are there. So we are having fast pinico T1, fast pinico T2, then we are having PD, that is proton density images, and we are having GRE or the gradient images, basically to look for calcium and hemorrhage. So all these sequences, although radiologist life is not only black and white, it is also having grayscale, but in this case, if you look at almost all ligaments, whatever you are coming across, they will appear black on all sequences, unless and until some hydration or the water is there or some fat is there. So likewise, some degeneration or normal. Otherwise, if you are coming across a bright is a red signal on any sequence, which is actually pointing towards the pathology. We sometimes take fat suppress. PD fat suppress is a routine thing, but if at all we are going ahead with contrast, we will take T1 fat suppress sequences post contrast. MR orthogram, again 2 types of orthograms are possible on MRI. One is direct, it is a minimally invasive technique, and we are directly instilling contrast in the joint. Another one is indirect technique, where we are giving it IV, asking patient to exercise, and that way that contrast is getting accumulated in the joint over the period. I am not going in detail about all these technique and sequences. We will directly move to MR anatomy. MR anatomy, again simplified it, just 4 different quadrants or 4 different parts. Most important from the even orthoscopic point of view is intercondylar notch, where there are only 2 ligaments, ACL and PCL. Then medial quadrant, a lateral part or the lateral quadrant, then patellofemoral joint. These are all 4 parts, what one should remember. So knee joint is that simple. One by one, we will just go through anatomy. Before that, one coronal view, just to show you different parts. As one can see here, is the intercondylar part, where you can see 2 ligaments are there, that is ACL and PCL. Looking here, fibula, this one is the lateral part. On lateral part, most important things, what you are seeing is 2 muscles are there. One is biceps femoris, which is on posterior aspect, and another one is deeply situated popliteus muscle. Then 2 ligamentous or the fibrous sort of tissue is there. One is lateral collateral ligament, and not to forget about the anterior part, that is the iliotibial tract. So just keep it simple. Other things are also there, but most of the things are in 2 and 4. So 4 things are here. Looking at the medial aspect is a little bit complicated, but you will remember them if at all you are know. What pes anserine? You know about pes anserine muscles? How many are they? 3 or 4? Some says 3, some says 4. But basically what we will remember, these are 3. So 3 pes anserine muscles or tendons, what we are seeing here, and these are sartorius, gracilis, and semitendinosus. So usually the gyros is consist of the four muscles. So where exactly is the semimembranosus? So semimembranosus is getting inserted on the posterior medial aspect of the tibia here. Then two ligaments, or we can say ligament complex. So this one is medial collateral ligament complex. This one is tibial ligament. Actually, tibial ligament is a thin part which is connecting the meniscofemoral and meniscotibial part. So it is not always seen on MRI. Moving to the next part, that is the most important, is the intercondylar notch. So intercondylar notch, it contains two important ligaments. I said everything is black. If it is white, it is a sign of some abnormality. So see here, this one is the anterior cruciate ligament. As the name is, anterior cruciate ligament. It is arising from the anterior part of the intertibial notch. It is coursing in the cross-like manner and getting inserted on L, that is the lateral condyle of the femur. So ACL is easy to remember, it is ACL. PCM is again similar thing, it is arising from the posterior part of the tibial intercondylar notch. It is crossing ACL, or it is coursing in a cross-like manner and getting inserted on the medial condyle of the femur. So such a simple thing is ACL and PCLR. Let's go through these few video images, which makes it really easy to understand or to see ACL, although this is not sagittal oblique view. If sagittal oblique, you can see ACL through and through. So this one is PCL. What one can see here is the PCL. Here is the PCL. And ACL is just starting here. This one is the anterior attachment of the ACL. And here one can see ACL. So this is sagittal oblique view, which is in the direction of ACLs. So look at ACL. ACL is having two important parts. One is anteromedial part, which is dark, and posterolateral part, which is little bit brighter. I say ACL is a ligament which is holding some fat, which is holding some fluid. So fat and fluid both are bright. So that may add to some impurity in ACL, but it will not always be causing tear, or it should not be taken as a tear. So some sort of brightness is always there, which is on posterolateral aspect. But if at all it is approaching anterior part, then it is abnormal. Looking at PCL, PCL is total black. We have seen PCL. So if you look at the PCL, PCL is totally black. As one can see here. So this one is PCL. So PCL arising from the posterior part of the intercondylar notch of tibia, coursing like this and getting inserted here. Again moving to ACL, look for the orientation of ACL. ACL is oriented parallel, little bit slanting anteriorly, and that too parallel to what? It is intercondylar notch of femur. So if this orientation is disturbed, there are high chances that there can be a tear. If any brightness is there are high chances that there can be tear. Most important part is footprint. So again one has to look for femoral attachment. Most commonly it gets damaged there. Mechanism I am not going in detail, but here again PCL and ACL. But seeing it in sagittal sections is really satisfying. However, one must compare it with coronal and the axial view. So in coronal view, how it appears? Let's see. Here is the coronal view showing the same. So I will just hold it. Here is actually a footprint of, or the insertion site of ACL, which is on the lateral condyle. And as one can see here, rest of the ACL can be seen if we go anteriorly. So here we are going anteriorly. This one is posterior part. Come on. Here we are going anteriorly. So this is the origin. Here is the intercondylar notch where the origin is, and here is the insertion. Similarly, one can follow PCL. Here we are following insertion of PCL. So it is posterior. It is two-way images I have taken. This should run like so. Here is the tibial attachment, what we are seeing right now. Here is the tibial attachment on posterior aspect. Here are the axial sections. In axial section also one can confirm those findings. So easiest way to look for ACL and PCL is to go ahead with sagittal oblique or the sag view, and you can just confirm it. To look for the footprint, best I think image is either coronal or go ahead with this image actually. Here what one can see in this particular image, here also you can see footprint better, insertions. So ACL and PCL, these are most important. ACL, PCL is dark only. ACL is having some impurity, some bright part, and one should be aware of all the pathologies. That is quite easy to make out. So let's just go through the medial knee joint space now. We have already discussed, so it is having pes anserine tendons. Pes anserine tendons are 3 in number. These are sartorius, gracilis, and semitendinosus. Let's go through, and we are having medial collateral ligament complex and tibial collateral ligament. These are the images. Simply we will go through. This is the medial part. In medial part, the posteriormost part, where we can see gracilis muscle, semimembranous, although here they are not getting inserted into pes anserine bursa, which is inferior to the insertion of semimembranosus, which is on the posteromedial aspect of the tibia. Here is the semitendinosus. So let's go through all these images. Yes, I will stop here. So again, see here, sartorius. We are having all these images on medial aspect, pes anserine bursa. Now started. Here, one by one we will go ahead with. So here came the medial collateral ligament. So medial collateral ligament closely and deep to medial collateral ligament is the tibial ligament. Tibial ligament we cannot differentiate from medial collateral ligament, so we are just considering it as a medial collateral ligament complex. Even few people consider, just a minute. This is very sensitive keypad. I don't have a mouse. I am trying to move it, and every time it may that. So you have a pointer? Yeah, I have a pointer, but trouble is actually I want to move those images and I want to show the pathology as well. It's okay. So here, concentrate on the medial aspect, my side of the screen. So we have cross pes anserine. Here is the medial collateral ligament and medial meniscus. So if at all we will look at lateral aspect now, again similar, hardly we have. If anterior to posterior we are going, we will see iliotibial tract first. Later on, we will see biceps muscle, which are actually two important tendons or biceps tendon on the lateral aspect. So let's go through. Here concentrate on lateral aspect. So should I stop here? So this one is biceps femoris tendon, which is getting inserted in the fibula. And what is seen here, which is actually medial to the lateral collateral ligament or the fibular collateral ligament, is a popliteus tendon. So popliteus tendon is medial to it. Again, it started on its own. Anteriorly, what one can see is iliotibial tract. So anatomy is real simple. So AI is actually coming in radiology very soon. It started working here automatically. Even without touching, everything is coming like that only. Anyway, it's great. So here is another video showing the same without any labels. I will try to show you here, starting from the anterior part. We have cross iliotibial tract. This one is fibular collateral ligament. That thick part was the fibular collateral ligament. Tibial. Here is the tibial and the medial. Come on. Usually multiple videos are there, it gets hang for a period. So even after your command, it will take some time. That is quite common in medical colleges where students also respond in the same way. They are get hanged and they will respond after some time. So from lateral knee, I am moving on to the next. That is anterior compartment. That is a patellofemoral joint or patellofemoral articulation. Again, images are there. It's really simple. We are having patella. On the either side, condensed fascia, that's patella retinaculum. Posteriorly, 3 bursae, infrapatellar, suprapatellar, prepatellar bursae, what one can see. This one is patella with medial and lateral articular facets. Then we are having, this one is femoral sulcus or the trochlear groove where patella is fitting into. So that anterior patellofemoral articulation part is really simple to understand. Pay attention to the articular cartilage, what is seen here. All of ligaments I said they are black because they are fibrocartilage. But if you look at articular cartilage, that is a hyaline type of cartilage. So its appearance will be different. So all these fibrocartilages, because of major fibrous content, they will be black. But if you look at this hyaline cartilage, it will be little bright on T2. But a little brightness one has to make out, we may have to go ahead with some different sequences, or one may go ahead with the GRE images which are already there with you. So GRE images show pathologies of the ligaments and menisci better. However, I am more comfortable with head side PD images. So in lateral view, again really simple, what we have is patella here, patellar ligament and quadriceps tendon. Here look at the patellar articular surface and patellar cartilage. Position of the patella, then install solvity ratio, which can give you idea about patella alta and patella baja. All the students there, they can remember is alta is above and baja is below, what we used to teach them. Again, here is a menisci. So we are moving to the menisci. If you look at the medial meniscus, both horns are triangular and they are sharply angulated on the medial aspects. I told you, menisci, they may be a little bright on T2 weighted images as compared to the T1. Moving to the next. Here, posterior horn is always larger than that of the anterior horn. If at all anterior horn is larger or of same size, suspect some tear there or maybe post-operative. So likewise, one has to properly take history. Never forget to look at the root. So posterior root is actually in relation to the posterior cruciate ligament and it is inserted here, just immediately anterior. If at all you can't see this particular image with a small root of medial meniscus which is inserted anterior to the PCL, suspect there might be a root tear. Then medial meniscus and lateral meniscus, they are entirely connected. So this one is the intermeniscal transverse ligament, what is seen frequently. Lateral meniscus, both horns are of equal height. Both horns are equal, but posterior horn is at higher level as compared to the anterior horn. ACL picture we had seen, this one is the normal appearance of ACL. And see here, this one, although this is T1 weighted images, one can see, we cannot make out ACL, which should have been here, obliquely oriented, almost parallel to that of the intercondylar notch of the femur. So AC is over. AC बंद है क्या? नहीं, मैं anxious हो गया मेरे को लग रहा है. Sorry. So whenever pathology comes, I become anxious. So here is the pathology. My wife is pathologist. That's why I am little more anxious. I shouldn't miss anything otherwise. So one cannot see ACL here. So ACL, absent ACL, disruption of ACL, partly or completely, one can make out easily on different sequences. Here is the another sequence. Can you make out where exactly is the problem? It is in the mid substance. Usually football player or the athlete injury, it involves mid substance. So mid substance tear is there, but one can see intact fibers. Sometimes there may be formation of some granulation tissue, and this granulation tissue may mislead you and may tell you that this ligament is intact, however, it is disrupted. And it may come into your hand and you will find that radiologist had written it intact, but this one is disrupted. So that is a problem whenever there is a granulation tissue or fibrosis already settled in injured ligament. Mucoid degeneration. It is not uncommon to find mucoid degeneration. This typical appearance like that of celery stalk is actually indicative of mucoid degeneration. Sometimes mucoid degeneration, along with that, some cystic changes are there. So cystic changes are common in all, whether it is menisci or the ligament. This cyst formation or the ganglion cyst formation, actually telling you that duration is very long, and it may point towards the pathology. If cystic changes are there, pathology is always there. Tear is always there. PCL tear. Again, PCL tear, they are somewhat rare as compared to the ACL tear. I had come across most of the time avulsion rather than. So such a strong ligament is the PCL. But here PCL with altered signals and disruption of the fibers, which is pointing towards the tear. A meniscal injury, actually you people are more well versed with. Only I will talk about interstitial tears are there. Suppose horizontal tears are there and they are, let's see what are vertical tears. Here is the posterior root tear, as one can see here, is the vertical hyperintensity or the brightness which is seen at attachment, posterior attachment near attachment of the medial meniscus, medial cruciate ligament. Here is the posterior root tear of posterior medial meniscus. One can see here is a vertical tear or horizontal tear, two tears in the same ligament. So these are, this one is a complex tear. So tear, making out tear is really easy. One can see the black, that is the appearance of meniscus, and this brightness which is pointing towards pathology. ACL injuries, they may associate with the LCL or the MCL injury. So let's see here. Here is the lateral collateral ligament complex, and what one can see here, disruption of this fibular ligament, and some collection is also there along the ligament. At the same time, if you look carefully at insertion site of the ACL, which is seen in same picture, one can see here some changes as well. So ACL tear with that of LCL injury. Here is also again LCL injury. One can see a tortuous course of the lateral collateral ligament and little bulk at fibular attachment, and again is associated ACL injury or the ACL tear. Similar picture with MCL, as one can see here, MCL ligament hardly seen. Although if you look at lateral collateral ligament is little thicker as compared to the medial collateral ligament. But together complex, we can say the complex. Complex, actually I was telling you about the complex. Complex is the tibial ligament which is actually a part very closely attached to the capsule. Then we are having medial collateral ligament and sometimes Cooper fascia. So Cooper's fascia is there's actually fatty fascia which is coursing from above downwards. So this Cooper's fascia is a part of complex. And even some fat stranding lateral to the Cooper fascia also points towards MCL complex injury. Here is ACL tear. So ACL tear along with medial collateral ligament injury, and if associated with medial meniscus injury or the meniscal tear as well, so it is an unhappy tear. So unhappy triad of Odenau. Am I right? So medial meniscus, medial collateral ligament, and ACL. Thank you.
Thank you, sir.
Thanks a lot.